Hello and welcome, everyone. I'm Dr. Janine Forrest, and I'm thrilled that you're joining the Dementia Unplugged Care Conversations today. We will be talking to a wonderful guest about care therapies that you may not know about. Before we get started, I do want to share this important message from the Dementia Society of America. All content, including any potential medical information, is provided as an informational resource only and is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by me, Dr. Forrest, and her guests are not necessarily the opinions and content of the Dementia Society of America. Thank you. Before we get started, I always like to make sure that we are understanding the same terms, the same nomenclature. When we talk about the word dementia, think of a visual of an umbrella because it is an umbrella term, meaning there are a whole variety of subtypes or conditions or diseases that present itself in ways that we call dementia. So there are numerous types. The most common you may be familiar with are Alzheimer's disease, vascular dementia, Lewy body, frontal temporal, and the list goes on and on. An important part to note, though, within this umbrella term, that the word dementia is not a disease in and of itself. So do not equate the two, although a disease can be an underlying condition. So a little bit confusing for many, but I just want to make sure that we're able to speak the same language. And so regardless of the types of dementias, the Dementia Society of America likes to offer these wonderful programs to support caregivers, people living with dementia, and family caregivers and professional caregivers as well. So with that background in mind, I do want to tell you that the Dementia Unplugged series includes not only care conversations, which is happening now, but stay tuned. There are other types of Dementia Unplugged programs in progress, musical connections and artful insights. So please stay tuned to information from the Dementia Society of America for these wonderful programs. Okay, so now I'm really excited to introduce our guest, Rachel Wiley, occupational therapist extraordinaire. Rachel is the founder and owner of a company called Day by Day Home Therapy. I will ask her to describe in more detail about what she does, but Rachel is a certified skills to care, is certified in skills to care for caregivers of individuals with dementia. An LSVT big for Parkinson's disease, and she is a certified dementia practitioner. She's also certified as a master trainer of skills to care through the Jefferson Elder Care and trains occupational therapists from around the country in skills to care program. Please know you can reach Rachel later by her website, daybydayhomecaretherapy.com. In terms of format, I'm going to be interviewing Rachel for about 30 minutes, and then we're going to open it up to question and answer, by which you can submit questions to the chat function. All right, let's get started and welcome Rachel. Thank you so much for being here.
Thank you very much for having me, Jeannie.
So I want to start out by please share a little bit about your background and your current work. And you have so many letters after your name. Maybe you can even help to decipher some of that for some of us who are less aware of about all that expertise.
Thanks, Jeannie. I would be happy to give you all a little bit more information about my background and my credentials. So the letters after my name, they look fancy, but MS just implies the Master's of Science that I have in Occupational Therapy. And the OTR/L stands for Occupational Therapist Registered and Licensed. The CDP is for Certified Dementia Practitioner. So there are a variety of professionals who can take a training to become a certified dementia practitioner. So that's a little bit about credentials. And in terms of my background, we mentioned that I am an occupational therapist and I have a niche in dementia care. So occupational therapists can work in a variety of settings with a variety of populations, but I chose to really focus on working with individuals with dementia and their care partners. So that is 100% of my caseload these days. I do work with clients through my practice, day-by-day home therapy, offering occupational therapy treatment to the person with dementia and integrating caregiver education into that treatment process. So that is reimbursed through insurance. I do accept Medicare Part B when I work with a patient. But we know that sometimes, for whatever reason, maybe the person with dementia can't be involved in the care process. Or, maybe doesn't want to, or there are some other barriers to that. So we can also offer caregiver consultation, but that would not be reimbursed through insurance necessarily.
Thank you. I just want to put a pause at the moment because maybe you can describe a little bit what an occupational therapist does.
Absolutely. I think that's a great question because I do get asked quite often, do you help people find jobs? And while that, I suppose could be something that an occupational therapist does.
Yes, other activities as a sign, right?
Exactly. So as occupational therapists, we define occupation as any activity that you do during your day. So that can really encompass a variety of tasks. That can be anything from bathing, dressing, grooming, using the bathroom, but it can be more complex tasks. It could be things like financial management, medication management, cooking, child rearing, taking care of a pet. It could be something like sleeping. So really any activity that you do, we call it an occupation. So occupational therapists can help individuals be able to engage maybe a little bit fuller in a lot of those activities.
Right, well, that helps. And maybe we could talk a little bit about why people don't know about how this helps with dementia, because that's really the talk here. What are those therapies? And I'm sure you'll list others, but particularly, why don't people know about this?
That's a great question, Jeannie. I think that there's probably a few reasons, a few different barriers. I think one challenge is that truthfully, many therapists, many occupational therapists don't even know that we can have a role in working with people with dementia. So I think that's a pretty big barrier that we have to overcome at the start. And I think the reason for that is, like many other professionals and many of the therapies we're going to talk about today, occupational therapists are trained to be more of kind of what we call a generalist, meaning they come out of school and they're trained to work with any population, meaning they could work with pediatrics or in geriatrics. So to educate professionals and train them in kind of a niche population is something that not all occupational therapists are aware of. And then I also think that there's a challenge related to a habilitation approach versus more of a rehabilitation approach, meaning, when we think about rehabilitation, we think about really restoring function or remediating or regaining skills that we've lost. And a lot of therapists, whether that be occupational, physical, or speech therapists, work with people with a rehabilitation mindset. And that mindset really doesn't apply to working with people with dementia. And I can expand on that at any point.
So maybe, let's make that more concrete for the listener. So what would that look like, right? You're assigned to care for someone, and if you have a rehab mindset, what does that look like in terms of goal setting and what you expect someone to do?
Absolutely. So if we have an occupational, physical, or speech therapist who has a rehab mindset, they're going to probably work with just the individual, just their patient, and not really consider the needs of what I call the dyad, or the person, our patient, and their care partner. So they might just be focusing on their patient and thinking about how do they restore function. So they're going to try to figure out how to get the person to either do the task again independently, or maybe walk again independently, or try to work on things like memory and attention. But we know with dementia that those likely are not reasonable goals. And so kind of connecting this back to your initial question about barriers, I think one of the barriers to finding therapies that are appropriate is that we have to find therapists who take a habilitative approach and not a rehabilitative approach. And that can be kind of tricky because there aren't as many out there.
Right. So you're sort of mixing apples and oranges. In my own practice, where I see especially families and get frustrated because these goals are set and then the person doesn't meet them. Right.
Yes.
And then they're sort of, quote, kicked out of the program. They're kicked out because they're not meeting goals.
Yes.
When in fact, it wasn't realistic to set that up in the first place. And people feel defeated. And family members get frustrated because maybe you're not doing the right thing, right? What kind of a therapist are you? And so you could just see this quagmire happening. So tell us more what habilitation means.
Absolutely. So habilitation is, again, I mentioned that concept of the dyad. And again, by that, I mean that the care partner should be integrated into the therapy. So it should really never just be a therapist working one-on-one with the patient 100% of the time. At some point, the care partner should be involved in the process to really identify, what our care partner needs, what's going to make their life easier in terms of how they care for the person with dementia. And also, involving them in the treatment process so that there can be some carryover, so that there's, so that we can collaborate and set realistic goals that are achievable, and we don't kick people out of therapy because they weren't able to achieve those goals. So in occupational therapy, I think about involving, let's say I'm going to work on bathing. I want to make sure that care partner is with me while we're addressing bathing with the person with dementia, so that when I leave, that care partner feels like they have the skills to be able to support the person on their own. Or in physical therapy, we shouldn't just be leaving a home exercise program for the person with dementia to do on their own. We should be involving the care partner to say, can you do these exercises with your family member? If not, why not? And how can I support you to figure out how to make this possible? And, similarly with speech therapy has a couple different roles, which we can talk more about in a moment, but same concept applies. We want the care partner to be involved in the treatment sessions.
I can stop you here and just want to illuminate the difference between occupational therapy and physical therapy. I think that can get fuzzy at times. Of when do you call who in, and do you need both of you at the same time? How does that work?
That's a great question too. And truthfully, I think it's fuzzy because we do have overlap a lot of the time. So I can understand why families are confused about, who does what. We do collaborate quite extensively on many cases. So I work with physical therapists kind of hand in hand with them with a variety of my clients, but particularly in cases where families are overwhelmed, maybe then it's a conversation between the physical therapist and the occupational therapist to figure out who's more appropriate first. I would say an occupational therapist is going to focus more on the functional day-to-day activities. So again, some of those things like dressing, bathing, taking medications, financial management, things like that, and also can help with some of the behavioral manifestations as well. Physical therapists are going to be appropriate if we notice challenges with balance, strength, even what we call transfers, or, trying to get up from a chair. Things like that would be most appropriate for a physical therapist. And would you like me to touch on speech therapy now?
Yes, please. Yes.
Speech therapy, again, kind of has a couple different roles. The referral I make to speech therapy most often is actually for swallowing challenges. So I think that's something a lot of people don't realize, that if your family member is kind of coughing while they're eating or having difficulty with swallowing, or what we call aspiration, so when they're actually kind of inhaling some liquid or food, that's a great chance to get a speech therapist involved, because they might be able to make some slight changes to the person's diet, in terms of, maybe they have some softer foods, things like that, and they can actually help reduce some of those challenges. So that's the role that I see speech therapy in most often. However, some speech therapists also attempt to address things like attention and memory, some cognitive functions. So sometimes you'll see referrals to speech therapy to address things like attention and memory. Again, this kind of goes back to our conversation about rehabilitation versus habilitation, and maybe how appropriate it is to try to restore things like attention and memory in dementia. It's probably not the most realistic, but I think we can kind of weigh pros and cons for engaging in that type of therapy on a case-by-case basis.
Mm-hmm. So I'm wondering, I'm a family caregiver, right? And I get this referral. How do I know? Is your philosophy more rehabilitative versus habilitative? And how do I even find that out to select the right one?
Absolutely. That's that's really challenging, because again, so many therapists focus on a rehab mindset that it's hard to figure out, what kind of model or philosophy they follow. I think the best thing to do is have that conversation early on, whether that be on the phone when you call to set up an appointment, or during that first, what we call an initial evaluation, talking to the therapist about, what kind of models do you use in your treatment? And also, what goals are you setting? Because we all have to set goals during our initial evaluation with a family. So making sure that you kind of involve yourself in that process. If they're not reaching out to you, you can kind of reach out to them and say, I'd really like to know what goals you think are achievable for my family member and what is my role in the treatment session. And that should give you an indication of their approach. If they don't have any plans to involve you, they probably don't have a habilitative approach, right?
Thank you very much.
The first indicator.
Yes, yeah, but that's clear. I can only imagine how many families just, how would they know that, right? How would you know if you don't know? I mean, it's exactly. So going back to, well, when do you bring someone in? So and then my second question to that, before I forget, is it different between early stage dementia and later stages? What can you paint that picture?
Yeah, all good questions. Let's see. So I'll start with, when do you bring someone in? If I start to get off track, Jeannie,
that's okay. I'm right there with you.
So when do you bring someone in? In terms of the type of work that I do as an occupational therapist with kind of this niche in dementia care, I love to be involved as soon as possible. So I get a lot of referrals from people who are kind of in a crisis situation. So there are kind of more extreme or challenging behaviors. And so we kind of have to work in this crisis mode to address it. I think it would be lovely to be more proactive. So as soon as we have that diagnosis, getting an occupational therapist in the home or a physical therapist just to say, things look good right now, or here are some things you can do to maintain this level of function for as long as possible. Or here are some things we can do to your home environment to make it as safe as possible. So there are some things we can do more proactively that I think it's great to get people involved, therapies involved as soon as possible. But certainly anytime there's a change or a challenge. So, all of a sudden my family member, or maybe not all of a sudden, maybe gradually my family member is resisting taking their medication. They're saying no every time I need them to take their medication. That's a great time to bring in an occupational therapist. Or, I've noticed that my family member seems as though their balance is a little bit off. Great time to bring in a physical therapist. Don't wait until there's a fall or wait until there's a challenge. In terms of speech therapy, and I think this is where, again, we get into kind of the pros and cons of all therapy. Early on, early on in the disease process, we might see speech therapists focusing more on, again, things like attention and memory. There's nothing wrong necessarily with that, as long as we're not seeing negative side effects, meaning we don't see that our family member is becoming agitated or stressed during or after the fact. As a side note, I had a client recently who was telling me about, we had a speech therapist on board and they were working on their cognitive exercises. And my husband became extremely agitated. And the speech therapist said to me, I really need to talk to the doctor about medication to handle that agitation.
Sorry.
Really, the conversation should be about, is the therapy benefiting the client or is it causing a stressful reaction? In this case, the agitated response, outweighed any sort of benefit that the patient was receiving from the therapy. So really we say, okay, thank you for trying, but speech therapy is not the most appropriate in that context at this time. And then to kind of loop back to the second part of your question, Jeannie, which is what does this look like at different stages? I think that physical therapy and occupational therapy certainly have a role throughout the entire disease process, or again, about throughout the spectrum of dementia and its progression. So early on, it might be more proactive. We might be setting, again, those routines or environmental adaptations to try to promote as a high level of function as possible for as long as possible. But certainly as dementia progresses, we can adapt our environment and the task and communication to address the changing needs of the person with dementia. And again, speech therapy, particularly later, is when we start to see some of those challenging issues with swallowing and aspiration. That's certainly when we want to bring a speech therapist on board as well.
You work with families because this is a progressive, underlying, many of the conditions are progressive, right, and decline. And has it been your experience, and my guess it would be yes, when you have families who get angry because you're not working them hard enough, or they're not saying, quote, improvement. And this goes hands in hand with the habilitation. Mm-hmm. But we know as providers that there's a lot of grief, and all of that goes along with it. So how do you respond to family members who want, my mom's not getting up and doing her exercises 5 times a day, and what's wrong? And again, how do you handle that piece?
Yeah, so that certainly comes up quite often, in the Skills to Care program, which we talked briefly about earlier. We actually rate what we call caregiver readiness, or their kind of understanding of where we're at in the progression. So that can kind of help me guide my treatment and learning, what sort of support does that care partner need at that time. But I do think that oftentimes what I'll say to care partners is, let's take a step back and let's kind of take a look at the big picture here. What is it that you're trying to achieve for your family member? What do we really want out of this? And if they say, I typically the conversation leads to, I want my family member to have the best quality of life as possible. We know that, we can't change the progression of dementia. So if we can give them the best quality of life that we can, usually that's the goal, right? So we want them to be happy and comfortable. So then we can kind of isolate whatever challenge they're concerned about. So something like physical activity engagement. Yes, physical activity is phenomenal for brain health. But when we think about the big picture, is it creating additional stress for the person with dementia and for the care partner? If the answer is yes, all right, then let's come up with something else that's going to be reasonable and doable without that degree of stress for both participants. Does that make sense, Jeannie?
Well, that makes total sense. So you talked a little bit about your Skills to Care. Maybe talk a little about what a program would look like for someone who might want your services.
Okay, yeah, Skills to Care. If any of you have heard of Skills to Care or COPE or TAP, all 3 of those programs kind of fall under the same umbrella. They were developed by many of the same researchers. So I talk about Skills to Care because that's my niche. That's what I do. But all 3 of these programs are very similar in nature. Skills to Care is an evidence-based program for care partners of people with dementia. It was developed in research for family caregivers, but we've used it with paid caregivers as well. there are kind of some structured components to the program, but in reality, it's very caregiver focused. So we take you through a fairly extensive questionnaire in the beginning to ask you, the care partner, about, are you having difficulty supporting your family member during, again, bathing, dressing, oral hygiene, car transfers? Do they have any of the following behaviors? Repeating, shadowing, resisting care, wandering, aggression, whatever it might be. And then we have you, the care partner, rank those challenges. So, you might say to me, my number one concern is that my family member has been wandering outside of the home. My number two concern is that they're resisting bathing. And my number three concern is I can't get them engaged in activity. And then we try to address one area at a time through a process that we call problem solving and brainstorming. So we try to figure out, why is this a challenge? What's contributing to the challenge? And then come up with some strategies and use an action plan for how to make that situation easier. And then we move on to the next area. So that's skills.
How long does something like that last? How long are you involved?
Great question. So typically, the way that I work in my practice, I typically see people about once a week, and could be anywhere from 5 or 6 sessions to 15 sessions. Really just depends on how many challenges the family member identifies. Skills to care can be reimbursed through a couple different modes, if you will. So I function as an outpatient provider, meaning I can have a little bit more flexibility in terms of the frequency or the duration of the program. Other occupational therapists might provide it through traditional home health, which means they might be in the home 2 or 3 times a week, but maybe not as many weeks. So it could vary provider to provider.
Thank you. That's very helpful. So as we're, believe it or not, time flies when we're having fun here. We're going to be moving towards close, but I thought I'd ask you, what got you into the niche of dementia care? What was it that sparked your passion for this?
Thanks for asking that, Jeannie. I've always loved working with older adults. My first job was as a diet aide in a nursing home as a teenager. So I've always had a love for working with older adults. But then on a personal note, my grandmother and both of her sisters actually passed away with dementia. Their maiden name was Day, so that's why I named my practice Day by Day Home Therapy. Okay. But, I really saw firsthand the challenges that my mom and her siblings went through in trying to figure out how to support my grandmother and my great aunts, but also just the lack of knowledge that's available and lack of support that's available in the community, particularly the knowledge gap in the healthcare community. So that's really what drove me to do what I do.
Yes, it's often our personal stories, right? Absolutely. That inform where we see the need to assist others. So thank you. Thank you for that.
Thanks for having me.
So for those of you who are listening, and we're so glad you're here, I hope there's some questions bubbling up. How can we get in touch with you, Rachel?
You can get in touch with me through my website, which is daybydayhometherapy.com, or you can email us, which is info@daybydayhometherapy.com. I know that's a long one. I hope that works. I would be more than happy to touch base with you and give you any information you need. And Jeannie, I don't know if they're looking for your information as well.
Yeah, I'll share that. But yes, thank
Perfect.
you. Thank you. Yes. So mine is Dementia Coach on Call, but I want to finish with you first. Okay. Mary Ellen Says, excellent presentation, very helpful and useful. Can professional caregivers take the skills training with Rachel?
That's a great question as well. So as of right now, skills to care certification is actually only for occupational therapists. However, we do have a variety of professional training that we do with formal or paid caregivers as well. Great question.
And where are you located, Rachel?
I am located in southeastern Pennsylvania. Currently, I'm licensed in Pennsylvania and New Jersey. So in terms of seeing actual patients, I'm doing a lot of telehealth in those states. However, I can do consultations outside of those states, and I'm more than happy to connect you with skills to care occupational therapists close to where you live if we have them. Finding local resources can be really challenging. I would say one thing that Dementia Society has is Dementia Answers, which is a directory. So you could try to start there and see if there are any local resources in the directory that you can tap into. The balance and overseeing all aspects of care, I can imagine that would be really overwhelming for a care partner. I'm only talking about 3 therapies right now, but if you have occupational, physical, and speech therapy, and you're managing physician appointments and the day-to-day, that can be overwhelming. So sometimes there are, aging life care professionals or care managers, some care consultants in your region who may be able to help support you with some of the managing the day-to-day.
Yeah, so Mary Ellen shared here that regional areas on aging can often direct resources as well. And then if you go to geriatric care managers, I think they're also excellent resources who help with a lot of boots on the ground, that coordination of care.
Absolutely.
What is and how do we find care managers? Do you want to share that?
Sure. So geriatric care managers are now called aging life care professionals. So if you just Google aging life care professionals, you'll find their national organization page, and you can type in your zip code and it will let you know if there are any nearby.
Excellent question. One of the major points that I heard in your talk is really working with therapists, whether that be OT, PT, or speech, in terms of the habilitation, habilitation model versus rehab.
Absolutely.
Because you're dealing with a brain that controls not only cognitive functions, but motor skills, right? And so that changes over time. Could be slow decline, can be quick, but it is knowing how to work with that. So it's more complex without making that person with the dementia or the caregivers feel like they're, quote, failing.
Exactly.
I think that is so important.
Yeah. We want to set them up for success.
Yeah. What an awful way to feel, right? When it's not their fault in the first place.
Exactly.
So that's my frustration. For those of you who are listening, I have my practice is called Dementia Coach on Call. And my background is in nursing. And I do a little bit more of a global education and coaching. So knowing when to bring in OT, PT, speech, those kinds of things, and connecting you to resources and doing sort of the education behind the scenes of why things are changing in the first place and what to expect. So that's how we work together as sort of multidisciplinary teams, because one person, one healthcare provider, one expert can't do it all. And the same message comes to caregivers. It does really, really take a village to care for someone well with any form of dementia.
Absolutely. And, I do think that's one of my kind of side projects is trying to educate more healthcare professionals, because I think even among therapies, I've been in a home after a rehab physical therapist has been in there and introduced a walker to somebody with moderate dementia. And then the family is upset because, they don't remember to use the walker. And I've told them a million times, and the PT said they have to use the walker. So we're setting someone up to not be successful if we're anticipating that someone's going to be able to kind of learn new information at that stage. So we really want to make sure from a healthcare standpoint that we're cohesive in our approach as well, so that the family doesn't get multiple points of view. Because I can imagine as a family that would be really challenging to try to decipher which profession.
And how do you know, right? I mean, this is new to you. Very first time you're in this, you're sometimes catapulted into this situation, right? How do you know? I mean, where do you start? And so that's where I have to highlight the Dementia Society of America, because I think do an excellent job of trying to pull all of these aspects together and having these tough conversations in care conversations, right? We're not just painting all the, the niceties of it, and there's a lot of benefits, but you can see how it gets very convoluted and complex, right? So that's important for family caregivers to know.
Absolutely. I think that's really important, Jeannie.
So I'm going to end with just one question, because I don't see any new ones. But my question is there any question we collectively, everyone on this call, has not asked you, or that you really want to drive home for people to know about the therapies?
That's a very good question, Jeannie. I think, again, you kind of reiterated the point that I want to make sure people know, which is that as care partners, being able to kind of be a little bit more assertive with your healthcare professionals and assert that you want to have an active role in the treatment of your family member, and making sure that they recognize how important it is for you to be involved, because you're the one that's caring for this person day to day. So you're the one who's going to be able to carry over techniques that may or may not work, and then report back to that therapist about, this was effective, this wasn't effective, we need to adapt to this. So really kind of asserting your role, that's okay to do. You're not stepping on any toes. This is a family impact, has a family impact. And so it's important for you to feel supported as much during therapy as your family member.
Wonderful. Well, Rachel, I can't thank you enough for taking this time and sharing your expertise. And I guess I'm biased, of course, but I think it has been wonderful. And the comments reflect that. So I want to thank everyone who's joined the call. Please tell others who you think might benefit from Dementia Unplugged Care Conversation. And thank you to the Dementia Society of America for hosting this program. And we'll see you next time.
Thank you all so much.
All right. Take good care, everyone.